Welcome everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniHealth.com, the website which is dedicated to teaching you about the human heart and its illnesses across the globe from one end to the other, primarily to educate you about the human heart, that is cardiology, and also increase your human heart awareness to keep you healthy. So my major initiative, which has been for years in my 35 to 40 years of practice, has been to improve the clinical outcomes by combining medical education to the patient education, as you know. And this is one of the things that I have strived for all along, and therefore we are showing MuniHealth.com in short video vignettes on two of our social media channels. So without any further ado, I'd like to delve into the subject matter. The subject today is acromegaly and its cardiovascular manifestations, if you will. So one of the things that cardiovascular complications, we'll call it. Acromegaly is because of two reasons. One, because you have an excess of human growth hormone, which is being secreted by the anterior pituitary, if you will. And the anterior pituitary, it is the somatotrophic cells, which are actually responsible for excess production of this human growth hormone. The other axis is related to the insulin growth factor type 1, if you will. So insulin-like growth factors, they are there and they're responsible. So the basic pathology is because of these two excesses that we see in the plasma and the serum. Now, it's because of, obviously, there's a tumor which is sitting in the anterior pituitary, which is just going on and producing these excess hormones. So because of the human growth hormone in excess, the entire body is actually gigantic, and organomegaly, literally in every organ will be seen. We are concerned about the cardiomegaly, obviously, in these patients because our focus is mainly heart. Now, besides cardiomegaly, one also sees heart failure, and one sees biventricular hypertrophy in these patients. And so that's another entity we come across. And there will be some conduction abnormalities, etc., that can develop, and we'll go over that in just a second. But primarily, it's because of cardiomegaly, CHF, and hypertension that these patients have high morbidity and mortality. They may also have CVA, increased incidence CVA. And just to note that only less than 20% of these patients actually survive beyond 60 years of age. So there is a mortality and morbidity really compromised because of all of these. So having said that, now let's understand what an EKG here will show. Well, these patients will obviously show some septal Q waves because of either biventricular hypertrophy that's present, or some STT changes, ST depressions chiefly, and T wave inversions will be present. But these are not related to ischemia, which I'll show you in just a second. If they were to have a nuclear MPI or myocardial perfusion imaging, these patients, only 20% to 25% of these patients will have a positive stress test, of which, when you were to subject these patients for cardiac cath, only less than 10% will have actual CAD. So most of the times, in fact, they have normal coronaries, and then they may have dilated coronaries as well, so which is very, very interesting. So the coronaries are not dilated. Now, let's go back to the schematic here. Right side of the heart here, and this is your left side. Some tricuspid valvular disease can be present. Some mitral valvular disease may be present. And invariably, it is the myopathy of the heart. So basically, it's the hypertrophy of the heart that is really the issue here primarily, which is really responsible for the entire cardiomyopathic picture. So basically, it's a cardiomyopathy that one sees, and that's related to the myocytes getting exposed. One, the size is enlarged. Numbers may not be enlarged, and therefore that's contributing to the left ventricular hypertrophy as well as the right ventricular hypertrophy. So there's a biventricular hypertrophy, if you will. There will be TR present here, and there will be MR also present, and some of these valvular regurgitations can actually contribute to the cardiomyopathy and also the morbidity in these patients, because that will contribute to the heart failure eventually. Now, if you were to do an echo on these patients, you'll see LV diastolic dysfunction. And one also sees, in addition, on a systolic strain Doppler, there will be some abnormalities. So systolic strain abnormalities will be present on Dopplers. And all of this, mind you, will all be reversible. If you were to treat this patient, this is all reversible if you were to treat the acromegaly. So if you treat the acromegaly per se, which we'll get to that in a second, and you will see that all of this can be reversed. As I said, the coronaries are free from any disease. Here's your aorta. I'm just quickly drawing my schematics. This is your left anterior descending, left circumflex goes down here. There are some branches coming around like that. And then, of course, you have your right coronary artery like here. So all of these branches, very, very few of them. So as I said, the coronaries in general, only less than 10%. Only less than 10% will show CAD, but otherwise it's not a feature. It's not a feature that's common to acromegalic cardiovascular complications. CVA, of course, occurs because of accelerated atherosclerosis. There will be insulin resistance that's increased. Remember that? Because, again, of the insulin-like growth factors, so insulin resistance is increased. There will be diabetic presentation, so increased higher diabetes incidence will be present in the acromegalics. And, of course, cerebral vascular accidents or CVAs, chiefly in terms of strokes that can occur. And that's primarily, I think, the pathogenesis because of the diabetic as well as the strokes, which are complicating the whole scenario, and therefore the incidence of strokes are also very, very high. So having said that, now what will be the treatment? Well, the treatment is transphenoidal resection of the tumor per se. So that's done, and believe it or not, the reversal and the remissions are excellent in these patients. Most of these patients do not require any further therapy after that, because once you remove the pituitary tumor arising from the anterior pituitary, chiefly the somatotrophic cells, the human growth hormone goes down, and that's followed, and then also the insulin-like growth factor, which is type 1, also goes down, because these are the two factors which are contributing to the myocytes and the cardiovascular complications. So having said that, now some of these patients can relapse, and when they relapse, then automatically we have a drug which is dopamine antagonist, and these patients can, the prototype being somatostatins. So these patients benefit greatly from somatostatins, and they have been there for a long, long time, and they have been provenly shown to have increased remissions following the resections if there were some relapses to occur. Now, you may have a refractory somatostatin therapy. So patients who are, again, refractory to somatostatins, those patients refractory to somatostatins, I'll call it SS, like the somatostatin therapy. If they were to become refractory to these patients, then we have let me write it down, pegvisomant. That's a difficult name, but it certainly is a drug which has been around for a few years. And again, clinical trials are underway still to really provenly say that this drug is wonderful and that can even take care of the somatostatin refractory type of remissions or relapses. But the fact is that pegvisomant is the only choice we have right now, and therefore, we are not waiting to have it proven. But the fact is that you keep it as a last resort, and you want to use it clinically if you have to. Okay, so in a nutshell, what you've learned is biventricular hypertrophy, which is the norm in these patients, and they are cardiomyopathic patients. Ischemic heart disease is very, very rare. As I said, in autopsy, less than 10% of these patients, so it's not an ischemia. Nuclear scans could be abnormal only in less than 25% of the patients, of which they go for cardiac cath, and most of these patients, they turn out to have a normal coronary, and in fact, they are dilated coronaries. So they don't have ischemic heart disease, as a matter of fact, in these patients. And then EKGs will suggest that there might be STT changes and T inversions, etc., and that will lead you to develop that. Now, one other thing I forgot to mention in the ECG also, that there may be conduction abnormalities. Now, conduction abnormalities will result into, there will be a lot of APCs, just remember that, and there will be a lot of VPCs, and that shows that there is some ventricular and atrial irritability, and it's not ischemic related. So they'll be randomly present throughout the Holter, throughout the telemetry monitoring if you were to do these patients, and it's not ischemia related. So just remember that, because even in stress-induced ischemia, if there was any, there would be any VPCs. But the fact is, there's not much stress-induced ischemia in these patients. They only a handful of patients really have an abnormal stress test. So that's the other thing. So most of these patients have, in fact, normal coronaries or dilated coronaries on the contrary. But the pathogenic mechanism is excess HGH and excess IGF type 1. So these are the two hormones by which the myocytes, we believe, are undergoing some myopathic changes, and that myocytic pathic changes, if you will, they are occurring at the myocyte level, and because they're not related to ischemia at all. Tricuspid regurgitation, mitral regurgitation, they are all incidental findings, and they're related perhaps mostly to the biventricular hypertrophy that sets in, which just disturbs the mitral apparatus and the tricuspid apparatus in respective ventricles. Echo will suggest the LV diastolic function we just talked about, and the systolic stress abnormalities, which all can be reversed, by the way, just so that you know. All of this can be reversed as soon as you treat the acromegaly, and we talked about the treatment as is. So I thank you again on this video for your attention to MuniHealth.com, where we talked about acromegaly and cardiovascular complications. Stay tuned for more newer subjects and more exciting subjects coming down the pipeline, and I'm excited to receive your suggestions, your comments each time whenever you write. It's very, very exhilarating to me, and I try to write back quickly as much as possible within a short period of time, if you will, given the time constraints, but I do write back always. And so your comments, your likes, your suggestions, your questions, and they are all very, very welcomed here. So thank you again for being on MuniHealth.com and continuing to support my clinical outcomes enhancement by medical education and patient education. This is Dr. Jaitly. So long.